Assalamualaikum and a very good morning to everyone. Welcome to second NRAS. Before I start with my presentation, I would like to thank the organizing committee for inviting me as a speaker. My topic today is Selective Trunk Block, or the acronym is SATB. Just to be clear, SATB has nothing to do with hemoptysis or this horrendous chest X-ray. Either SeTB or 2TB has no relationship to tuberculosis. So back to the outline of my presentation. First, I'm going to enlighten you so that you have a better understanding of SATB. Then I'm going to point out the common blocks for upper limb in our daily practice, the indications and anatomy. Next, I'm going to show you step-by-step and structures related to SATB. What are the common pitfalls? And lastly, I'm going to demonstrate you a video on how SATB was being performed. I think everyone agrees that SATB is a novel RA technique. It was introduced in 2020 when the world was hit by COVID-19 tsunami. At that time, we were facing challenges when there are cases like proximal humeral fracture surgery. We tried to avoid GA and AGP. However, fortunately, Tognu and colleague, they shared their experience using SATB for such cases. SATB is a hybrid technique, a combination between interscalene and supraclavicular block. It anesthetizes the entire upper extremity, which covers C5 till T1 dermatome, with the principle that the majority of the innervations to the upper extremity arise from the three trunks of brachial plexus, which is the superior, middle, and inferior trunk. So, maybe some of you will wonder, does SATB is a one-size-fits-all technique, or is it an all-purpose technique for upper extremity surgery? At the end of this lecture, I'm sure you will get the answer. It is impossible for me not to mention brachial plexus when explaining upper limb block. So just a quick recap. Brachial plexus is divided into roots, trunks, divisions, cords, and branches. With this knowledge, we can match the type of blocks and the level of brachial plexus. For example, interscalene blocks the roots of brachial plexus, supraclavicular blocks the trunks and divisions, infraclavicular blocks the cords, and axillary blocks the terminal branches. So what do we have now for upper limb blocks? We have interscalene, supraclavicular, infraclavicular, axillary, costoclavicular, and retroclavicular. Just for your knowledge, just for your information, that costoclavicular and rep here is another approach for infraclavicular. We also have hybrid techniques. We have axis, which is the combination between axilla and interscalene brachial plexus block. We have reverse axis. We have UGSCIS, which is the combination between interscalene and supraclavicular brachial plexus block. And we have infraclavicular suprascapular nerve block. Now, maybe some of you will ask, what is the difference between UGSIS and SATB, because both are the hybrid techniques for interscalene and supraclavicular brachial plexus block? So the simple answer, yes, it is the same. However, I would say that SATB is a more improved and better blocks because we have a proper reference to perform SATB. Let's do some comparison of upper limb blocks. First, the indication. The interscalene is indicated for shoulder surgeries. Sometimes, depends on the spread, can be used for proximal humeral fracture surgery. For supraclavicular, it is indicated for elbow, forearm, and hand surgery. Sometimes for proximal humeral surgery, again, depends on the spread. For infraclavicular and axillary, both are indicated for elbow, forearm, and hand surgery. And for SATB, it is indicated for shoulder, proximal humeral surgery, fracture surgery, elbow, forearm, and hand surgery. So we can conclude that SATB is an all-purpose RA technique for upper extremity surgery, which covers C5 till T1 dermatome. The level of brachial plexus I have mentioned previously. The LA volume for we need about 10 to 20 mils of LA for interscalene, 20 mils for both supra and infra, about 30 mils for axillary, and for SATB we need 25 mils. Usually we inject 7 mils at the superior trunk, 8 mils at the middle trunk, and 10 mils at the inferior trunk. So from this information, we know that the hybrid techniques, for example, UGSCIS, will need at least 30 to 40 mils of LA as compared to SATB, which only needs 25 mils. For number of injections, single injections only needed for interscalene, supra, and infra. Sometimes we need 2 injections for axillary, depends on the locations of musculocutaneous. And for SATB, we need 2 injections, the first at the interscalene level and the second one at the supraclavicular fossa. What about HDP or phrenic nerve palsy? Interscalene will have this effect. Supraclavicular sometimes depends on the spread of the LA, and unfortunately, STB, the incidence as high as 80%. So SATB is a hybrid technique, so I'm going to explain the sonoanatomy for both interscalene and supraclavicular brachial plexus block. So from the international consensus on the anatomic structures to identify the structures in UGRA, we need to identify 4 structures for interscalenes. They are the anterior scalene muscle, medial scalene muscle, C5 nerve root, and C6 nerve root. For the orientation scanning, we need to add 1 more structures, which is the superior trunk of the brachial plexus. This is just to show you that the roots of brachial plexus is sandwiched between 2 scalenus muscles, the middle and anterior scalene muscle. Cross-section anatomy, the position of our transducer, and we can identify the nerve roots C5, C6, and C7s, and 2 scalenus muscles. So once we have identified these structures, we need to aim and inject our needle in between the roots, and we should feel a pop after the needle has passed through the prevertebral fascia. So this is just to show you the needle incision placement of interscalene. Then the recommendations for supraclavicular, we only need to identify 4 structures. They are subclavian artery, first rib, trunks and divisions of the brachial plexus, and pleura. So once we have identified these 4 structures, the brachial plexus is actually superficial and posterolateral to the subclavian artery. So sometimes in one view, we can identify all the 3 trunks, superior, middle, and inferior trunk, and we need to be careful of the vascular structures such as the dorsal scapular artery. Sometimes the transducer position, sometimes we need to tilt away our transducer from the neck in order to get a better view. So this is the most important slides of my presentation. I'm going to explain steps and structures to identify STB using SUIT, which is sequential ultrasound imaging technique. There are 7 steps in SUIT. The first step, we start at the supraclavicular fossa. So we need to identify the brachial plexus on the posterolateral aspect of the subclavian artery. The position of the patient, supine position with arm in neutral position. The neck is slightly extended and the neck is turned away to the contralateral side. The next step, we need to identify C7 transverse process and ventral ramus. So C7 has unique sonomorphological features, which it has only single posterior tubercle here, okay? And then sometimes we can identify the muscular slip between the bifid C6 ventral ramus and C7 ventral ramus. The presence of this muscular slip might explain why our LA cannot spread from middle trunk to the inferior trunk. We can use our color Doppler to identify vertebral artery. The C7 ventral ramus is located lateral to the vertebral artery and anterior to the C7 transverse process. Then we slide our transducer cranially to identify C6 transverse process and ventral ramus. C6 transverse process has this prominent anterior tubercle, and it's higher and taller compared to the anterior posterior counterpart. C6, okay, and the hypoechoic C6 ventral ramus is emerging between the two tubercle of C6 transverse process. Then we slide cranially our transducer to identify the C6 transverse process and ventral ramus. So the C5 transverse process is equal in height, and the hypoechoic C5 ventral ramus emerging between the two tubercle of C5 transverse process. Next, with some manipulation and tilting, we need to identify the superior trunk, middle trunk, and C8 ventral ramus. The superior trunk is formed by the fusion of C5 and C6 ventral ramus, and the middle trunk is located in between the superior trunk and C8 ventral ramus. The C8 ventral ramus is located on the top of the T1 transverse process and the first rib complex. Then we need to identify the superior trunk arrangement from lateral to medial. As we have to note the SPA arrangement. S stands for suprascapular, P stands for posterior divisions of the superior trunk, and A stands for anterior division of the superior trunk. And the last step, we need to go back to the supraclavicular fossa to identify the inferior trunk. The inferior trunk is formed by the fusion of the C8 and T1 ventral ramus. So T1 ventral ramus emerging from under the first rib and coming to lie next to the C8 ventral ramus. Okay, so this is the second injection after we inject the middle and superior trunk. Common pitfalls. The neck is a highly vascular area, and we must avoid injecting the vascular area, the vascular structures, especially the dorsal scapular artery and transverse cervical artery. C5 often travel outside the interscalene groove. C6 is usually two elements. Epinurum of C5 and C6 roots are usually poorly defined. Inserting the needle between the roots is unnecessarily risky because we can induce peripheral nerve injury. Phrenic nerve palsy is high, about 80% with the volume of LA. Inferior trunk sparing can occur between 4 to 36%, even with the corner pocket injection. And unfortunately, SATB does not cover the medial aspect of the arm, which covers by the intercostal brachial. So here is the video I did. Okay, I performed this SATB on this patient for distal humerus surgery. So if you can notice here, it was a little bit challenging because the sloppy supraclavicular fossa. So step one, from at the supraclavicular fossa, I identify the brachial plexus and the subclavian artery, which is lateral to it. Then I need to identify step number 2, C7 transverse process and ventral rami. Okay, here. Okay, then I use the color Doppler to identify the vertebral artery, and the C7 ventral ramus is lying next lateral to the vertebral artery. Okay. So this was like 4-hour surgery. I give anesthesia to this patient. Then C6 transverse process. We can see the hypoechoic C6 and C5 transverse process. The hypoechoic C6. Then I went back to the supraclavicular fossa to identify the inferior trunk. Okay. This is after I injected LA. Okay. So now let's see the needling technique of okay. So I start injecting my needle at the interscalene area, okay, from lateral to medial. So I target the superior trunk once I felt a pop. So you can observe a pop here. After I felt a pop, I injected 7 mils of ropivacaine 0.5%, okay, over here. After I injected the LA, I withdraw and redirect my needle to the middle trunk. Okay, once again, I inject and a pop is felt. Then I inject about 8 mils of ropivacaine 0.5% here. Okay, I'm injecting the LA here. So as you can see, both the superior trunk and middle trunk is deposited with the local anesthetic. Then I slide my transducer to the supraclavicular fossa and try to inject LA to the inferior trunk. Okay, this is my needle. I target at the corner pocket, and then once a pop is felt, I injected 10 mils of ropivacaine 0.5%. Okay, injecting the LA. So this is the LA. Okay. And you can see the inferior trunk was floated nicely. Okay. So the procedures was 4 hours procedures and 100% anesthesia. We supplement with TCI remifentanil. So at the end of the operations, all are happy, all were happy, the surgeon, the anesthetist, and the patient, pain-free. Okay? Thank you very much.